invite Dr. Gururaj Chantri sir to chair this session. Our third speaker brings warmth, clarity, and deep clinical wisdom to the podium as he speaks on humanizing care in cardiac anesthesia. May I invite Dr. Suresh Rao KG, Co-Director of Institute of Heart and Lung Transplant at MGM Healthcare, Chennai.
Very good morning, all. It's a great pleasure to be here, and I thank the organizers for giving me the opportunity. Now, no, it's not going. Yeah, heart to heart, that is donor's gift to the recipient's new lease of life. How to make it lovely. It's a great topic, but I will restrict myself to the medical and surgical aspects of heart transplantation. I'll start with brief history of heart transplantation, look at various indications, contraindications, and discuss about the pathophysiology in the pre-transplant period and in the post-transplant period, and brief note on donor heart, ischemic time, and perioperative management of heart transplantation, and few of the case scenarios from our own series. The first heart transplant was done in 1967 by Christian Barnard, and 1981 cyclosporin was introduced. That's how patients started living. And 1984, first pediatric heart transplant was done. And in 1994, tacrolimus was invented, so the outcome became better. Now, if you look at the heart failure, stages A, B, C, medically managed, it is in stage D, they will have refractory symptoms. So you need to do something more. This is the time you consider heart transplantation. On the right side, there is Seattle heart failure model. And if we put all the data, symptoms, it will give risk of mortality because of the heart failure in the next 2 years. If the risk of mortality is more than 50%, then that is a time to consider heart transplantation. So we have certain criteria before the transplant. You have to have maximal medical therapy, and any alternative procedures like CABG, valve replacement, repair, all those things should be tried. Then you look at the VO2 max, that is the maximum oxygen consumption. If it is more than 14 ml per kg, they are too well to undergo a heart transplant. If it is less than 10, they will have the greatest survival benefit. Now, what are the indications? One is cardiogenic shock, where they require mechanical circulatory support. Or if they have refractory heart failure and they are on continuous inotropic support. Or NOHA class 3, 4 symptoms with poor prognosis. Or they have progressive symptoms, worsening of symptoms despite maximal therapy. Or if they have hypertrophic or restrictive cardiomyopathy with severe symptoms. Sometimes there may be refractory angina. They are not amenable to any kind of revascularization. It's not possible. Or recurrent life-threatening arrhythmias, not amenable to any kind of therapy. All those procedures, EP study, ablation, all those things are done. In spite of that, they have arrhythmias. Probably you have to consider heart transplantation. Then cardiac tumors, some of the congenital heart diseases like hypoplastic heart syndrome, failing Fontan, these are all indications for heart transplantation. Now, that's how you do the VO2 max. Patients cannot run on the treadmill or walk on the treadmill, so use the bicycle to measure the VO2 max. Now, what about the contraindications? If the patient has got severe pulmonary hypertension with high PVR, it's an contraindication. or active malignancy, again a contraindication, active infection. Then there are some relative contraindications like age. Usually above 65 we do the transplant. But you can see in the picture, that guy at the age of 78, we did the heart transplant and he's celebrating his 80th birthday. So age is not an absolute contraindication. Patient severely diabetic, again a relative contraindication. If the patient has got COPD, restrictive lung disease, or acute pulmonary embolism, in that case, heart transplant alone is not good enough. So we can go for heart and lung. And if he has cirrhosis, heart and liver, severe renal dysfunction, then heart and kidney may be required. Coming to the pathophysiology. Before the transplant, basically they have heart failure. So left ventricular end diastolic volume is high, LVEDP is high, LA pressure is high, they have pulmonary congestion. And they also have elevated catecholamine levels and renins. This is to keep the cardiac output as well as blood pressure. And they will be on diuretics, so there can be hypokalemia, there can be hypomagnesemia, or they may be hypovolemic. And also because of the chronically elevated catecholamine levels, there will be downregulation of the adrenergic receptors. What about the post-transplant period? Basically, you are putting a heart which is denervated. There is no nerve control. So there is no neurogenic response, like no baroreceptor mechanisms to compensate for acute hypotension. But they can have humoral response by release of catecholamines, which takes some time to compensate. And again, any indirect acting drugs like ephedrine, digoxin, dopamine may not be effective in these patients. So heart failure patient, they have to wait for heart transplant for some time. They may be very sick. They may be on inotropes. So sometimes we put them on inotropes. You can see the boy with the ambulatory milrinone. Sometimes they may have acute cardiogenic shock. So we put them on ECMO, VA ECMO. So they will have to wait for a transplant on ECMO. And sometimes this child had severe heart failure, but normal lungs. So we put the child on LVAD. So there is a cannula which drains the blood from the LV and it is returned back to the aorta through an external pump. So we could maintain the child for 1 month before the heart transplantation. Coming to the donor. So we need to match the donor and recipients. So usually we do ABO compatible transplant. But in pediatric patients, we also do ABO incompatible, in which case you have to measure the anti-A, anti-B titer. If it is high, you have to reduce it by glycosol filter or plasmapheresis. Now, donor and recipient weight, that should be matching. 20% deviation is fine. We also look at the left ventricular hypertrophy, especially if the cause of brain death is because of the cerebral hemorrhage, they will have LV hypertrophy. So we measure the LV mass index, then accordingly you take a decision. If the recipient is PRA positive, again you have to do the CDC cross-matching. If it is positive, again we'll have to do plasmapheresis to reduce the PRA. Echo, detailed echo, evaluation by the echo is important. You have to look for any LV dysfunction, valvular abnormalities, or congenital heart disease. And if there is moderate LV dysfunction, you can try using the anotropes, anodilators, improve the ventricular function. If it improves, you can take it for transplant. Transport is very important. So sometimes we use air ambulances, sometimes we use commercial airlines, in which case you have to book a seat for the organ box also. And when you are transporting by road, we usually create green corridor, so there is not much wastage of time in transporting the organ. Ideally, the ischemic time should be less than 4 hours. If it is a short distance, probably you can use the drone also. And you also have organ carrying system where you can perfuse the heart using an external pump so that you can prolong the ischemic time. Coming to the anesthetic induction, you have non-invasive monitors, SpO2, EKG, temperature, EtCO2. bispectral index monitoring, NIRS. Invasive, again invasive blood pressure, CVP, pulmonary artery pressures, continuous cardiac output, and transesophageal echo. Induction with the etomidate, fentanyl, muscle relaxants. You need to give surgical prophylaxis, antibiotics. If they are on AICD, you have to interrogate and probably inactivate it. And we should be ready to go on bypass anytime while induction because these patients can crash. Maintenance, avoid nitrous oxide, and usually we maintain with the inhalational agents and opioids. And you'll have to withdraw the PA catheter. Otherwise, while cutting the SVC, they may cut the PA catheter also. And going on bypass, they use high aortic cannulation. And ventilation, usually we use low tidal volume, 6 ml per kg to have protected ventilation. Coming to the immunosuppression, we use basiliximab and methylprednisolone. Coming to the surgical approach, it is the LA anastomosis first, then the IVC anastomosis, then the pulmonary artery anastomosis, and finally the aortic anastomosis. At the end, we do the SVC anastomosis. Once the aortic anastomosis is over, you can release the cross clamp. And while weaning off the cardiopulmonary bypass, usually the heart starts beating with sinus rhythm. If not, you may have to use pacemaker. Once the heart starts ejecting, you reinsert the PA catheter, start inotropes. The most important thing in the immediate post-CPB period is to keep the pulmonary artery pressure low, PVR low. Otherwise, they can develop right ventricular dysfunction. Because the donor heart, the RV is used to normal PA pressure. Suddenly you put it in a recipient whose PA pressures are high, there may be RV dysfunction. So you may have to use inhaled nitric oxide, IV sildenafil, etc. Now what are your hemodynamic targets once you come off bypass? The heart rate around 100, mean arterial pressure around 70 with systolic pressure of 100 and CVP less than 12, cardiac index more than 2.4. And post-operatively, they may require 6 to 8 hours of ventilation, and you have to monitor the RV function. There may be RV failure in the post-operative period, so you have to keep the PA pressure as low as possible. And we need to give cytomegalovirus prophylaxis and also prophylaxis for opportunistic infections. And you may have to do EM biopsy and DSA to monitor for any rejection. These are the immunosuppressants we use. Usually we use triple drug therapy, steroids, mycophenolate, tacrolimus. And T is very essential. So you can look at any mechanical complication like SVC anastomotic area. There may be narrowing or IVC narrowing may be there. All this can be diagnosed with T. And of course, you have to look for any LV dysfunction, primary graft dysfunction, organ rejection, or right ventricular dysfunction. Coming to our own experience, we would have done around 700 plus heart transplants, of which 150 are pediatric heart transplant, 45 heart and lung transplants. So, interesting case, 2-year-old baby had dilated cardiomyopathy, pulmonary hypertension, also had stroke, conservatively managed, then underwent orthotopic transplant. In the post-op period, patient developed RV dysfunction. So you can see the echo, the LV is contracting well, RV is hugely dilated. So we supported with the inotrope for a week's time, then finally the RV completely recovered. So you can see the small RV here, and in the right side, that is the baby who had the heart transplant. This is one more case, 54-year-old guy, dilated cardiomyopathy with high PVR. We did the transplant, that is because there will be reversible component of the PVR. However, in the post-transplant period, patient developed RV dysfunction because of the high pulmonary artery pressure. So we didn't settled with the inotropes, so we put the patient on ECMO, VA ECMO. So you can see the on ECMO, LV function is good, but the RV is severely dilated. And we supported on ECMO for 1 week's time. That is on the left side, the patient is on ECMO, next day we extubated. But we continued the ECMO for 1 week, and right ventricle completely recovered and we could take off the ECMO. This is another case scenario, 24-year guy, dilated cardiomyopathy, had cardiac arrest, did ECPR. He was on ECMO for 7 days. Then we converted ECMO to LVAD. LVAD is no oxygenator. There are two cannula. One drains the blood from the LV, other one returns the blood to the aorta using an external pump. And finally, after 2 weeks, he had the heart transplant. You can see the heart functioning well on the left side of the screen. So to conclude, the most important thing when the patient, you have to look for the PVR and transpulmonary gradient. If the PVR is high, patients can develop right ventricular dysfunction. That is one thing. Second thing is intraoperatively, post-op period, keep the pulmonary vascular resistance as low as possible. Otherwise, there will be RV dysfunction. And of course, they can develop renal dysfunction because they are on tacrolimus. So we'll have to monitor for this. We have to do the tacrolimus or cyclosporin levels. And you have to have the surveillance for rejection by means of echo, DSA, and EM biopsy. So that is the pre-transplant patient, and after 4 years, so that's how heart to heart, how it looks slowly. Thank you.
Thank you, sir, for sharing your expertise with us today. It was a honor to chair your session. And sir is from this place only. Thank you, sir.
Thank you. I think it's good to be back in KMC. My friend Mali is here, so it's good to see all my friends. Thank you again. Any questions, I'll be happy to answer.